في الواقع I find it very difficult to talk after everything was been. There is nothing left for me. They discussed the receptors, the immunological reaction, everything. Anyway, let us start. Dry eye Sjogren syndrome. Yes, here we are. So it's a chronic autoimmune disorder affecting exocrine gland like lacrimal and salivary glands. It's either a primary, which is isolated, or secondary, with rheumatoid arthritis and systemic lupus, and it is more in women than in men, 9-1 almost. And it affects all the layers of the tear film. They affect the aqueous, the lipid, as well as the mucus. Regarding the aqueous, by lymphocytic infiltration of the lacrimal gland, causing atrophy and fibrosis, this will reduce the aqueous part of the tear film, and this will also stimulate an inflammatory cytokines, causing ocular surface damage. The tear film instability, because we know that the aqueous is the largest component of the tear film, and with the reduction of this will reduce the volume and increase the hyperosmolarity with reflex inflammation, and this will induce the inflammation cascade with increased cytokines, and MMP9 will cause further damage to the cornea, conjunctival epithelial cells, and this is the circle that continue. Again, if we talk about the goblet cells are responsible for the mucin, and loss of goblet cell will reduce your mucin secretion, and these are responsible for distribution of your tear film over your cornea. So once you lose them, there will be poor tear film spreading, and this will increase the friction. Also, it has an neurological involvement, will affect the cornea sensitivity and reflex tearing, will again increase the symptoms. And let us leave this now, go here for clinical presentation. Dryness, grittiness, burning sensation. Signs are conjunctival injection, reduced tear from meniscus, filamentary keratitis. The diagnostic criteria, 3 for us, which is number 3, 4, and 5, ocular staining score, Schirmer test, tear film breakup time. These were discussed again, but outside you can ask for positive anti-Sjogren syndrome antibody with RO antibodies, which are also in Sjogren and lupus erythematosus. And then also you can ask for labial salivary gland biopsy, because it is usually both glands are affected. Ocular surface staining, fluorescein, this was discussed this morning. Schirmer test again. All these were discussed this morning. Schirmer test paper, Schirmer test, tear film breakup time, and ocular surface staining. These are the different types of filamentary keratitis and diffuse staining with many quadrants, and also this was discussed, how do you distribute them according to the quadrant and position, inferior, superior, and all these things. Meibomian gland dysfunction, this is also another factor which is important for the lipid, and we know that the lipid is the covering area that prevents evaporation of your tear film, and it has a mixed mechanism, either with Sjogren syndrome, aqueous deficiency, or we don't know exactly how it is, but meibomography is essential for all these cases, and you may need to do a gland expression to get rid of this fat. Differential diagnosis, either non-Sjogren syndrome, which is like post-LASIK, age-related, or medication-induced, like anti-glaucoma and so on, chronic conjunctivitis, and neurotrophic keratopathies. Serology, we discussed that, anti-Sjogren syndrome, RO, anti-Sjogren syndrome B, and antiocular antibody. Salivary gland biopsy. Treatment goal is to relieve symptoms. This is the major thing, by lubrication, reduce inflammation. Topical immunomodulator, again, this was discussed. Topical steroid or immunomodulator, this is discussed by Dr. Safwan just now. And to prevent complication, this is the most important with our scarring and corneal ulcers. Management, there is first line with artificial tears, punctal plugs, and lid hygiene. All these this morning. Again, if we go to the second line, topical corticosteroid, everybody agree that short-term starting with topical steroid essential, and then cyclosporine A 0.1 is essential. Liftigras also works faster. And management according to the stage, whether it's mild, moderate, or severe. In the mild stage, you have dryness, Schirmer test between 5 and 10, normal staining. Then here you need only patient education with artificial tears. If it is moderate with persistent symptoms and positive staining, more tear film breakup time less than 5, you have to go for anti-inflammatory with punctal occlusion. But in case of severe, then you have to go for autologous serum, scleral lenses. These at least they left something for me not to be discussed, which is scleral lenses and systemic therapy. So first-line treatment, aqueous-based, lipid-based, all this was discussed. Inflammatory topical steroid, cyclosporine, liftigras. They left nothing. Punctal occluder. Punctal occluders, they are temporary silicone, so either temporary or permanent, and they are helpful, especially in aqueous deficiency, not in other types. And moisturizing chamber goggle. These are also a good idea and will give some relief to the patient. Autologous serum or platelet serum, both of them are helpful. The autologous will contain the growth factor, vitamins, cytokines, effective epithelial healing, and severe dry eye. Typically, it is 20 to 50 dilution and refrigerated. And this everybody can do it in his medical center. Platelet-rich PRP are also important, either as drops or injected into the lacrimal gland and subconjunctival tissue as injection. My daughter is taking care of this. She's good in that one. Contact lens, scleral lens. Scleral lens is a big lens. It's not touching the cornea, and it is a reservoir. So it's a vaulting lens. It's a reservoir, especially with persistent epithelial defect and severe keratopathy. Systemic therapy, we can go for systemic strategy, hydroquinones, and biological factors. Advanced autologous serum, these all mentioned. Systemic therapy, hydroxyquinone, immunosuppressive. All these things this morning very well covered. Complication prognosis, we know that corneal ulcer, perforation, of course, vision quality will be disturbed. So it's okay. So most probably, I really talk about nothing except the scleral lenses. How do they work? And the punctal plugs. How do they work? That's it. I didn't add anything else. Thank you very much. Next time, put me the first so I can cover, not at the end.